This lecture covers some renal topics. Hydronephrosis. This means kidney swelling that occurs from buildup of urine. The hydro is trying to reference the liquid, the urine, and the nephrosis is simply acknowledging that the urine backup is causing a problem for the kidney. To make sense out of hydronephrosis, you must minimally know the remainder of the gross anatomy distal to the kidneys. So from the two kidneys, you go via the matching two ureters to the single bladder. Then from the bladder, there is a single urethra that goes out of the body. The point is that if there is a block somewhere, it can mean the urine gets backed up before that, and enough backup can cause swelling. Blood flows into the kidney first via the renal artery, then goes through progressively smaller arteries and arterioles. After renal artery, then segmental arteries, then interlobar arteries, so between lobes, then arcuate arteries, which curve and thus have also been called arciform, then interlobular arteries, this time between little lobes, in other words, between lobules. Then we get to the famous afferent arteriole, which is afferent with respect to the glomerulus. That is, it bears blood to the glomerulus. It approaches the glomerulus. Everything up until this point has been about blood flowing into the kidney. At the glomerulus, we have one of the few ways that we can start heading out of the kidney. That's the kidney's main function, right? To take some of the stuff that's in the blood and put it in the urine, and then you void it, for example, into the toilet. And if it goes out via the glomerulus, we call it filtration. After the glomerulus, blood flow can pass via the efferent arteriole to the peritubular capillaries, whence solutes can undergo secretion into the several portions of the tubules. The opposite movement, so from tubules back to the peritubular capillaries, also happens, and this process is called reabsorption. Then after the peritubular capillaries, blood continues via veins. The interlobular vein, then arcuate vein, then interlobar vein, then renal vein. To recapitulate, blood enters the kidney via the renal artery and eventually arrives at the afferent arteriole, then the glomerulus. Via the process called filtration, stuff can enter the nephron here at the glomerulus. Then blood goes from the glomerulus via the efferent arteriole to the peritubular capillaries. Via the process called secretion, stuff can enter the nephron here at the peritubular capillaries. Now, if we've left the blood at either the glomerulus or the peritubular capillaries, we traverse the tubules and arrive at the end of the nephron at the collecting duct. And our collecting duct and the literal million other collecting ducts, because each kidney has about 1 million nephrons, dump into what are called the calyces, and each calyx dumps into the renal pelvis. By the way, pelvis is just the Latin word for basin, so again, this isn't the pelvis that most people think of when they hear that word. It's just the catch basin in the middle of each kidney. Now, we said that from the two kidneys, urine goes via the matching two ureters to the single bladder, and thence via the single urethra that goes out of the body. With a little more detail, we go specifically from the renal pelvis past the ureteropelvic junction, which I have also referred to as the pelviureteric junction, which of course I like because then we are saying it proximal to distal. Then the ureter courses under the gonadal arteries, then over the common iliac artery. So now it is at the pelvic inlet, and here we mean the inlet of the bony pelvis. The pelvic inlet can also be called the superior aperture of the pelvis, and it can be said to define the boundary between the abdominal cavity and the pelvic cavity. The ureter then courses under either the uterine artery in a female body or the vas deferens in a male body. Next, it gets to the ureterovesical junction, And since vesical here refers to the urinary bladder, that's what's next, the bladder. The actual opening after the junction is called the ureteral orifice or ureteric orifice. Urine leaves the bladder via the urethra. To get to the urethra, we first pass the internal urethral orifice. There's an internal urethral sphincter, which has sympathetic input via the hypogastric nerve, and later an external urethral sphincter, which has somatic input, so we control it, via the pudendal nerve. Side note, I'm mentioning these nerves here because they come up in the study of micturition. The cause of hydronephrosis is usually obstruction. We said earlier that if there is a block somewhere, it can mean the urine gets backed up before that, which in turn can cause lumens to dilate. Obstruction can be secondary to kidney stones or injury to a ureter. It could also be congenital. This is the prostate sitting right under the bladder. BPH is short for benign prostatic hyperplasia. Hyperplasia is too many cells, and we can take benign to mean it is not capable of metastatic spread, as in via the blood or lymph. Benign prostatic hyperplasia is common in males over 50 years of age and preferentially hits the lateral and middle lobes of the prostate, which are periurethral. Thus, when they undergo hyperplasia, they can collectively squish the prostatic part of the urethra. Another way to obstruct from the outside that can instead happen in female-bodied patients is cervical cancer. I won't try to describe here what constitutes stage 3B, other than that the B part, as opposed to A, tends to mean greater lateral spread. But in stage 3B cervical cancer, we have reached out far enough to squish either ureter and thus can cause hydronephrosis on that side. In the United States, this might be less common than worldwide because of the pap smear, which serves as a screening test for cervical cancer. So some ways to cause hydronephrosis are kidney stones, injury to a ureter, obstructions in the urinary tract that are there from birth, benign prostatic hyperplasia if it's severe, and late-stage cervical cancer. When hydronephrosis happens, the other kidney can still perform the job of filtration of the blood, unless what? Well, if the patient has only one kidney, there is no other kidney to compensate. Or if both kidneys are obstructed, then again, there isn't an unobstructed kidney to compensate. If we have uncompensated obstruction, glomerular filtration rate should drop. If GFR goes down, we expect the serum creatinine to rise, as the way creatinine exits the serum is mostly by filtration. So, summarizing, we expect increase in serum creatinine in patients who have only one kidney and it is experiencing hydronephrosis, or who have two kidneys but both are currently exhibiting hydronephrosis. Okay, let's tie it all up. Blood enters the kidney via the renal artery and eventually arrives at the afferent arteriole, which is the one that approaches the glomerulus. Going out via the glomerulus is termed filtration. If we don't get out here, the blood exits the glomerulus via the efferent arteriole and passes next to the peritubular capillaries, from which solutes can be secreted into the tubules. Anything that has left the blood by either filtration or secretion can, unless it's reabsorbed, ultimately arrive at the collecting tubules, which dump into calyces, which in turn join up at the renal pelvis. By the time we get to the renal pelvis, we can safely call that liquid urine. If there is a block anywhere downstream of here, the urine can back up and cause the dilation and swelling of the kidney, which we refer to as hydronephrosis. Heading out of the pelvis, there's a ureteropelvic junction, then the ureter, which goes under the gonadal artery, over the common iliac artery at the pelvic inlet, and then, depending on the patient, under the vas deferens or the uterine artery. Then past the ureterovesical junction and the ureteral orifice and into the bladder. And then we pass the internal urethral orifice and the two urethral sphincters, the internal and the external. And now the final portion of the journey is out via the urethra. Causes of obstruction that result in hydronephrosis include nephrolithiasis, ureteral injury, late-stage cervical cancer, congenital malformations, and benign prostatic hyperplasia if severe. If we have hydronephrosis and don't have another kidney with normal function to compensate, glomerular filtration rate may drop and creatinine levels may rise in the serum. That is, the patient may experience acute kidney injury.
Okay, that's it for this one.